Good evening, ladies and gentlemen. I am Brigadier Dr. Tathagata Chatterjee. I am currently a faculty and a senior professor at ESIC Medical College and Hospital. It's a super specialty hospital at Faridabad, Delhi NCR. And this is a hospital where I've been for the past 3 years in the Department of Hematology, a senior professor in pathology, and of course, heading the Department of IHBT. This is a department where we have started an MD program in both pathology and in IHBT. Also, we have started our transplant, stem cell transplant program. Past 2.5 years, we have done 45 transplants. We see a huge number of cases, including lymphomas. The Department of Pathology, with the guidance which I've given them, they have really standardized the approach to lymphomas, particularly the morphology and the IHC basis of lymphomas. So with this introduction, let me bring you greetings from this beautiful college where I am here for the last 3 years, ESIC Medical College, Faridabad. It's a 750 bedded hospital and it has a medical oncology, clinical hematology, and all the super specialty wings. This, of course, is where my story started, Armed Forces Medical College. I'm an alumni of this college. And to begin from the beginning is 1997, when I was doing my postdoc fellowship at Tata Memorial Hospital, Bombay. Those days it was TMH Bombay and not Mumbai, as you all know from now. And we had a fantastic team of senior faculties, dedicated teachers, and to name a few, Dr. Anita Borges, Dr. Roshni Chenoy, Dr. Krishnamurthy, Dr. Chitralekha Soman. Actually, Chitralekha Soman was the head of the department and she had just come back from Kiel. Kiel is in Germany, where the Kiel classification came. So they used to, start the topic in a very, very different manner to watch to what all of you are exposed to these days. They used to start with poetries and the poetries were made by them. And this is not copied from any books. They were genuine teachers. Of course, I'm not denying there are a lot of genuine teachers even now, but the practice of teaching and the commitment and the passion was seeing is believing. And I was fortunate to be exposed in 1997 to this team. So one such poetry I remember is lymph nodes are cell aggregations by lymphatics resembling stations. Their round cell collections drain down from infections and deal with immune information. And it was all jargon for me because there were so many new classifications which were knocking on the door. But Kiel was there. The real classification, that is the revised European American lymphoma classification, was just about to be launched. And there were a jargon and a confusion, plethora of names, various types of lymphomas having various names. So they coined this poetry. Lymphomas have T cells of B, IgM, IgA, or G, centrocytic, centroplastic, with names quite fantastic, like KI1 or AILD. So that's how they used to start the, chapter on lymphomas. So, well, with this little bit of, satirical introduction, let me go to ontogeny, which is the basis for immunohistochemistry, which is the basis for morphology. So as you all know, B cell neoplasms correspond to various stages of normal B cell maturation. And that is precisely what lymphoma will be all about. They correspond to various stages of normal B cell maturation. So the precursor B cells in the bone marrow will develop into a mature naive B cells. And this term is very important and hence it is kept in bold. Mature naive B cells. Now this mature naive B cells has got two options. It can either develop into a short-lived plasma cells or it will enter the germinal center. Now two things take place in germinal center and these are very, very important. One is somatic hypermutation and the second is heavy chain class switching. So once these two procedures take place, you know that the cell has gone through the germinal centers. And there are telltale signs which tell us that these are the cells which has undergone, somatic hypermutation, which is fantastic amount of point mutation in the VDJ region of the heavy chain and the light chain regions. So these are the most important points in which a lot of somatic hypermutation and point mutation takes place, making that antibody capable of encountering many, many more antigens, so they become stronger, antibodies by the process of somatic hypermutation. And then the heavy chain class switching, the IgA, the IgG, the IgM, everything takes place. And importantly, the centroblast in the germinal center will undergo apoptosis and develop into centrocytes. Now we'll see the significance of this sentence because you will soon see why the centroblasts are BCL2 negative. And BCL2 is something which we use very commonly in our immunohistochemistry panel. So remember, the centroblasts have to undergo apoptosis and develop to centrocytes. So the BCL2 has to be negative. We'll discuss that as we proceed with this lecture. The post-germinal cells will include either the long-lived plasma cells or the memory or the marginal zone cells, as we call it. So accordingly, a precursor B cell neoplasm can give rise to a B lymphoblastic lymphoma, which, if it spills into the blood, becomes acute lymphoblastic leukemia. The pre-germinal center neoplasm, that means the naive mature B cell, which has not yet entered the germinal cell neoplasm, will go to the mantle zone, that is the topmost part of the germinal center, without entering into the germinal center. And these are the cells which form the mantle cell lymphoma. And we'll see the immunohistochemistry of these specific regions and accordingly how we achieve the diagnosis. The germinal center neoplasm essentially are the follicular lymphomas, the Burkitt's lymphoma, the diffuse large B cell types, which is germinal center type. We'll discuss that later. And of course, not to forget Hodgkin's lymphoma. So these are the four neoplasms which occur from the germinal center. And the post-germinal center neoplasms are the marginal zone lymphomas, the Molt lymphomas, the lymphoplasmacytic lymphomas, the small lymphocytic lymphoma CLL, the diffuse large B cell lymphoma, particularly the activated B cell types, and the plasma cell myelomas. So this tells you exactly, based on ontogeny, from where a likely lymphoma is going to emanate or originate. So the ontogeny is the most important aspect of understanding lymphoma and immunohistochemistry. So coming further, the B cell ontogeny and lymphomagenesis. From the precursor neoplasms in the bone marrow, which forms the acute lymphoblastic lymphoma, to the CLL, SLL, which can be either pre-germinal center or post-germinal center, we'll discuss that. To the mantle zone lymphoma, which is again a pre-germinal center. To the Burkitt's, the DLBCL, the CG type, that is the germinal center type, the follicular lymphoma, these are all from the germinal center, and of course the Hodgkin lymphoma. The marginal zone lymphoma and the DLBCL activated B cell type, which is the post-germinal center, and of course the plasma cell dyscrasias of the multiple myeloma, which emanates from the plasma cells. So accordingly, the bone marrow, the interfollicular area, the follicular area, the perifollicular area, and the perioral blood and the extranodal tissues will give rise to a plethora of non-Hodgkin's lymphoma, and the entire thing is based on B cell ontogeny and lymphomagenesis. I hope you are understanding. Slowly, I'll build up the topic so that you will know by the time we enter the immunohistochemistry why certain cells are taking a particular monoclonal antibody and why certain cells are not taking. So the B cell ontogeny and lymphomagenesis, to precisely explain to you further, so it becomes a foreign antigen independent cell to a foreign antigen dependent cell to a terminal differentiation cell, which is a plasma cell. The foreign antigen independent cell starts from the stem cells, the pro-B cells, the pre-B cells, and the immature B cells. The foreign antigen dependent cells will be the mature naive B cell, the germinal center cells, the memory B cell, and the terminal differentiation will be the plasma cell. The immunoglobulin genes will be germline in the stem cells and the pro-B cells. However, in the pre-B cell, there will be a mu chain in the cytoplasm. So cytoplasmic mu chain is the earliest immunoglobulin heavy chain rearrangement, which is seen in the pre-B cell. And the immature B cell will have the immunoglobulin light and heavy rearrangement, and they will be membranous. We'll discuss that. Coming to the mature naive B cells, they'll have both the heavy and the light chain rearrangement, the IgM and IgT membranous. The germinal center cells will have heavy and light chain rearrangement with a somatic hypermutation and class switch, as I have explained earlier. The memory B cells will have both the heavy and light chain rearrangement, and so will the plasma cells. And accordingly, if you see the foreign antigen independent cells, the markers or the IHCs will be CD34, CD19, CD79A, the BSAP, the CD34 once again, CD10 and TDT, followed by a CD19, a 45, a 79A, a 34, and a 10, and a TDT in the pre-B cell. And of course, the immature B cell will be 19 positive, 20 positive, 45 positive, 79 positive, CD10 positive. So the large B cell lymphomas or the acute lymphoblastic lymphomas If it originates from the pro B cell, you have got specific markers. From the pre B cell, you got specific markers, and the immature B cells, you got specific markers. And all these things are based on the ontogeny. Similarly, the B cell mantle cell lymphomas will be 19 positive, 20 positive, 45 positive, 79A positive, DSAP positive, and CD5 positive. But we will see how the mantle cell and the CLL differ, or the small cell lymphoma differ, as we progress further in this lecture. The Burkitt's, the follicular lymphoma, the lymphoplasmacytic lymphoma, the DLBCL, and the classical Hodgkin's lymphoma, they generate from the germinal center. So accordingly, they will have a CD10 and a BCL6 positivity, which is the classical features of a germinal center marker. So besides the B cell markers of 19 and 20, the BCL6 and CD10 will now suddenly come into the play, which will tell you that they are emanating from the germinal center. The marginal zone cells and the BCLL post-germinal centers will be BCL6 negative, CD10 negative, besides being positive for the B cell markers. And the plasmacytoma and the myelomas will be 38-138 dual positive. We'll discuss that accordingly. So ontogeny, naive B cells. These are CD5 positive cells. What are these cells? These are small resting lymphocytes in the peripheral blood, and they are also seen in the primary lymphoid follicles, and therefore they are seen in the follicle mantle zones. They are always BCL6 negative. So when you're dealing with a mantle cell lymphoma, remember, there will be CD5 positive, but BCL6 negative. The moment BCL6 becomes positive, you're dealing with the germinal center cell. So the mantle cell lymphoma is out. Now the germinal center centroplasm, as I said, the centroplasm have to undergo apoptosis to switch to centrocytes. Hence the BCL2 has to be switched off. So the BCL2 is switched off as centroplasm, the CD10 becomes positive, and the BCL6 becomes positive, which are both germinal center markers. BCL6 then becomes negative in the memory B cells and the plasma cells. So BCL6 are always negative in plasma cells. The two important markers which have recently come in IHCs are the LMO2 and the HGAL in the germinal center cells. So sometimes, in case you are having a doubt, you can include LMO2 and HGAL as a germinal center marker. Now remember, you have a light zone and a darker zone in the germinal center. The darker zones are because of the basophilic cytoplasms of the centroblast, whereas the lighter zones are the centrocytes. The centrocytes in the lighter zone express the surface membrane immunoglobulin and BCL2 and are BCL6 positive, right? The BCL6 and IRF4 are always reciprocally expressed. That means IRF4 will be positive in plasma cells, but the BCL6 will always be negative in plasma cells because the BCL6 is downregulated as the cells cross the germinal center. Plasma cells, remember, they lack the surface immunoglobulin, they lack CD20, but they will express MUM1 IRF4, 79A, and of course the classical 38 and 138. Coming to the T cells, antigen-specific T cells mature in the thymic cortex. You all know that. So you have a cortical thymocytes and the medullary thymocytes. The cortical thymocytes will always express TDT along with CD1A, CD3, CD5, and CD7. CD7 is called a pan T cell markers. So there's the plethora of T cell markers plus TDT and 1A will be cortical thymocytes. And remember, they will be double negative for both 4 and 8. So that is cortical thymocytes. When you come down further to more mature, the medullary thymocytes, they will express mature T cell markers. So they will either be CD4 positive or CD8 positive compared to the cortical thymocytes, which are double negative for 4 and 8. NK cells are negative for the surface CD3. They will express CD16 and CD56 besides CD2 and CD7. And the gamma delta T cells, which mature before the T cell receptors, they lack the CD4 and the CD8 as well as CD5. So this, in nutshell, is the ontogeny of the B and the T cells. Now, the CD4 positive T cells are the T helper cell 1 and T helper cell 2. You know that. T helper cell 1 will secrete interleukin 2, whereas T helper cell 2 will secrete 4, 5, and 6. The T helper cell 2, as you will see in angioimmunoblastic T cell lymphomas, they provide help to the B cells in maturation. What are the markers of T follicular helper cells? The markers of T follicular helper cells are BCL6, CD10, and these two are readily available in any of your labs. Along with that, you have CD4, which is a T helper cell marker. Along with that, CD57, CD279 or PD1, and CXCR5. And you will see subsequently in AILD or AITL, you need at least 2 of these T follicular cell markers in a appropriate molecular and a morphological setup to call it AITL. So immunophenotyping with IHC remains an essential diagnostic tool for mature lymphomas in combination with cytogenetics, molecular genomics, clinical, radiological, and other laboratory tests. So each of these are complementing each other and not just one aspect. So lymphoma is a clinical pathological issues where we take into combination the cytogenetics and the molecular genomics along with the clinical radiology. Now, as a technique, immunohistochemistry is relatively easy to perform. It is readily available in diagnostic labs compared with the flow cytometry or the genetics and the molecular studies. Although flow is fast and requires less material, IHC is advantageous because the immunohistochemical profiles and the cytomorphological features can be evaluated simultaneously. And that's what we pathologists are all about. We are essentially morphologists where the IHC complements what we have already diagnosed on the morphology. So the applications of IHC can be to identify the cell lineage, to detect specific genetic alterations, to visualize degree of cell proliferation like the Ki67, and of course to identify therapeutic targets like rituximab, that is anti-CD20. So there are various applications of IHCs in lymphomas. Now coming to cell lineage. Now first and foremost, a CD3. A CD3 is a pan T cell marker. It is expressed in more mature TNK cell lymphomas except anaplastic large cell lymphoma. Remember, in anaplastic large cell lymphoma, whether they are ALK positive or ALK negative, CD3, which is a pan T cell marker, is difficult to find as a positive marker. So you have to do some other T cell markers along with ALK or a CD30 to find out whether you're dealing with ALCL or not. We'll discuss that later. CD20, this is a pan B cell marker. And as you know, this is expressed in most mature B cell lymphomas. CD79A is a very good alternative to CD20. And what does it do? It compensates for its loss due to plasmacytic differentiation of tumor cells. So whenever there is a tumor cell with a plasmacytic differentiation, you will not get a CD20 positive, but you will get a CD79A positive. So which means you must use both CD20 and CD79A simultaneously, particularly when you're differentiating a plasmacytic differentiation of tumor from a routine lymphoma. Also, if there's a history of rituximab therapy, the CD20 will be negative, but the CD79A will be positive. So it's a good clinical practice to include both 20 and 79A when you're discussing cell lineage of the B cell. Of course, CD56, you know, is a neuroendocrine marker, and so is an NK cell marker. Sometimes the specific genetic alterations can also be found out by IHC. For example, the characteristic translocation in follicular lymphoma, that is a BCL2, the mantle cell lymphoma, that is CCND1, that is translocation 1114. This can be detected by overexpression of BCL2 and cyclin D1. Cell proliferation, the Ki67 is one of the most important markers in your hand. It reflects the degree of tumor cell proliferation in cell cycle phases except the G0 phase. Identify the therapeutic targets. With the development of immunotherapy, PDL1, CD19, CD30 are all used as biomarkers to identify therapeutic targets. The clinicians will ask you when you're discussing a peripheral T cell lymphoma, is CD30 positive? What is the percentage of CD30 positive? Because they are going to give you an anti-CD30 monoclonal antibody as a treatment. Most important, proper fixation of specimen is the most critical event for optimum results. All processes from tissue collection to the final pathological diagnosis must be performed appropriately for the accurate lymphoma diagnosis. So now let's see the checklist, the thought process. What are you thinking of? Have you thought of this as a B cell neoplasm? Yes, I have. So do an ISC or a flow. So you do an ISC. We are discussing ISC today. What is the pattern? Is the pattern diffuse or is the pattern follicular? What are the type of cells? Are the cells small? Are the cells medium? Or are the cells large? Are the cells variety of shapes? Are the cells pleomorphic or are these cells monomorphic? Cyclin D1. Is cyclin D1 positive even if CD5 is negative? Is CD10 positive? Does Ki67 show high proliferation index, say more than 90%? Then you're thinking of Burkitt's lymphoma. So this is the checklist or the thought process which should be there in your mind when you're thinking of a B cell neoplasm. Does the Ki67 show a high proliferation? Check for Epstein-Barr virus. So LMP1, latent membrane protein 1, is easy to standardize in your lab instead of the ISH, that is in situ hybridization of EBV. So you can check for Epstein-Barr virus by LMP1. Check if CD10 is negative. Put an Hans algorithm. We'll discuss Hans algorithm shortly. That is BCL6, MYC, and MUM1. And rather BCL6, CD10, and MUM1. But in addition to the Hans algorithm, you can put a MYC and a BCL2, particularly when you're discussing a morphology which is looking Burkitt-like or like Burkitt's. So, does the cells express both BCL2 and MYC? Are we dealing with the double hit lymphomas? So, you have to do a FISH for all high-grade lymphomas because, as you will see later on, the BCL2 and MYC in ISC are not surrogate markers for FISH. So, certain cases of lymphoma, particularly high-grade lymphomas, particularly double hit lymphomas, you have to do FISH. And that's how your checklist ends. So what is known? Now, the 2017 WHO classification recognized the germinal center B cell as the germinal center type and the activated B cell or the ABC type based on the molecular subgroups of DLBCL, and this was based on gene expression profiling. GCB, that is the germinal center B cell type, and the activated B cell type of diffuse large B cell lymphomas differed in their chromosomal alterations, activation of signaling pathways, and of course, clinical outcome. We knew that the GCP fared better than the APC. However, the gene expression profiling or GEP is not available as a routine in clinical tests. And because there are issues of reproducibility and reliability of IHC algorithms, subclassification of DLBCL NOS was considered an option in the 2008 classification. Practical problems. Frozen paraffin sections of these neoplasms often are diagnosed as poorly differentiated non-hematopoietic neoplasms. And the end result is what? They are wrongly treated with aggressive chemotherapy or even unnecessary surgical procedures. And therefore, the favorable outcome of a diffuse large B-cell lymphoma is lost. So you as a pathologist must be very, very clear about your morphology and the IHC before giving a diagnosis of diffuse large B-cell lymphomas. So when you do a sampling, multiple touch imprints comprising of single cells are important. If the touch imprint shows lymphoid follicle, preserve it for flow. If there are small samples, then take sections and do IHC simultaneously. Flow cytometry will give you the clonality in very small samples. FISH, of course, can be performed on paraffin-embedded samples. So you have to be very careful when you sample your tissue because many of the tissues will be used for many extra diagnostic procedures. So now let's talk about DLBCL, the recommended IHC panel, and the variants of DLBCL. So what are essential? The essential is CD3 for a T cell marker, CD20, a Ki67 for proliferation, a CD10 and BCL6 for the germinal center markers, a MUM1 for an activated B cell marker, a BCL2, a c-MYC, and an Epstein-Barr virus in situ hybridization, or you can do an LMP1 IHC. So these are essential whenever you're dealing with DLBCL. Of course, optional in a resource crunch situation, CD79A, CD30, 23 ALK, and 138 has to be added. Now, when you do an essential, it is essential. There is no compromise. Optionals are when you're dealing with certain other varieties. For example, a CD30 positive diffuse large B-cell lymphoma, right? Or a Epstein-Barr positive diffuse large B-cell lymphoma, or a plasmablastic lymphoma which is CD138 positive. So all this morphology will essentially make you arrive at an optional panel, but the essential panel cannot be compromised. The typical IHC results of a DLBCL NOS are characterized by a large atypical CD3 negative and a CD20 positive lymphocytes with a Ki67 labeling index greater than 80%. And this gives you essentially an idea of what you're dealing with. Choice of markers. CD45 has to be used judiciously. When CD20 is negative and you're thinking of a B-cell marker, as I said earlier, use another B-cell marker since CD20 is negative in 2% cases of large B-cell lymphoma. Particularly as a morphologist, if you're suspecting plasmablastic lymphoma or even an ALK positive B-cell lymphoma where CD20 is negative, so you must apply a CD79A. So a CD79A is added in conjunction with CD20, particularly when you're suspecting plasmablastic morphology. Also, you must apply PAX5 in all cases, including when you're suspecting Hodgkin's lymphoma. Hodgkin's lymphoma are weakly PAX5 positive, but they will be positive. So this is the way you use your markers judiciously. Now, the cell of origin classification of DLBCL is performed by staining for CD10, where the cutoff in the tumor cells is 30%. BCL6, again, the cutoff in the tumor cells is 30%. And MUM1, where the cutoff is again 30%. So what do? You apply Hans algorithm. A positive CD10 expression in more than 30% of neoplastic cells will classify this patient with a DLBCL with a GC phenotype or a germinal center phenotype. And this, as I told you earlier, has a better overall survival rate than that of patients with a normal GC phenotype. Now, a double expressor is which is expressing both BCL2 and c-MYC. So we have got a cutoff. The BCL2 cutoff has to be 50% in the tumor cells, and the c-MYC cutoff has to be 40% in the tumor cell. In addition, you must do an Epstein-Barr virus in situ hybridization or LMP1 in the detection of Epstein-Barr virus positive DLBCL. So the cell of origin is CD10 BCL6 MUM1 will divide your DLBCL into either germinal center type or activated B cell center. So we got a huge amount of algorithms like the Hans algorithm, the Choi, and the Tally. And as I said, the gene expression profiling is not routinely available, and hence IHC comes in very, very reliable. And in fact, it is a surrogate marker for the molecular subtyping into GCP and AP subtype. And this can be done by using any of those algorithms, Hans, Choi, and Tally. However, we use Hans commonly. So in Hans algorithm, we use three markers, the CD10, the BCL6, and the MUM1. The algorithm developed by Choi uses 5 markers, and this is consistent in 93% of results with gene expression profiling. So this is very good. So what are the 5 markers you use in Choi? Besides BCL6 and CD10 and MUM1, which you use in Hans, you can use FOXP1 and GSET1. The Tally method uses an equal number of both germinal center markers and activated B cell markers. So germinal center markers includes GSET1 and CD10, and the activated B cell markers includes FOXP1 and MUM1. A new marker, LYMP-only transcription factor 2 or LYMPHOMA, determines the immunophenotype of germinal center B cell, and it is a very, very specific marker of germinal center B cell. So now coming to the Hans algorithm. So 3 markers, CD10, BCL6, MUM1. Now if the CD10 is positive, you're absolutely sure it is a germinal center B cell marker. If the CD10 is negative, apply BCL6. If the BCL6 is positive, apply MUM1. And if the MUM1 is negative, again you are dealing with the germinal center type. However, if the BCL6 is positive and the MUM1 is positive, you're dealing with the non-GCP type or the activated B cell types. So these are the algorithm of Hans. CD10 is a marker normally expressed in centroblast and centrocytes of reactive germinal center cells. The tumor is classified as germinal center B cell positive if there is more than 30% CD10 positive tumor cell population, regardless of the results from the other 2 markers, which means if you've got a CD10 and it is more than 30% positive in the large B cell lymphomas, you are dealing definitely with the GCP type. MUM1. This is normally expressed in plasma cells or post-germinal center B cells. MUM1 expression in DLBCL suggests the possibility of a non-GCP or the ABC type or activated B cell type. Similar to CD10, BCL6 is a marker in centroblasts and centrocytes of the germinal center. It may also be positive in many ABC DLBCs. Therefore, when BCL6 expression is positive in more than 30%, it is classified as GCP only when the MUM1 expression is negative. Whereas CD10 is an independent marker of germinal center. But if BCL6 is not an independent marker, so if BCL6 is positive and MUM1 is negative, then you're dealing with the GCP type, as I've explained to you in the algorithm. We will not discuss Choi algorithm because we don't use it, but you must know the antibodies which are using in Choi as well as in Tally. Now, germinal center DLBCL versus ABC. In germinal center DLBCL, if the sample is CD10 positive, BCL2 negative, and Ki67 label more than 95%. Now you will get this scenario. Then the possibility is Burkitt's lymphoma, and this is the most important differential diagnosis. So any large B-cell lymphoma is not GCB type. So the buckets will come, particularly the Ki67 labeling index more than 95%. And so you have to do the MYC fluorescence in situ hybridization FISH. So the ISC in bucket lymphoma, CD20 positive, CD10 positive, BCL2 negative, TDT negative, cyclin D1 negative. That makes it bucket. And in morphology, any GCP DLBCL and buckets may look alike. So the Ki67 gives you a huge clue. More than 95%? Yes. Starry skies pattern? Yes. You are dealing with buckets. Now, to diagnose double hit lymphoma, that is high grade B cell lymphoma with MYC and BCL2, all the patients of DLBCL would compulsorily have a FISH testing for MYC rearrangements ideally. Therefore, the patients who have been found to have a MYC rearrangement should have FISH for BCL2 or BCL6 rearrangement, and that is compulsory. The IHC is not a surrogate marker for FISH. The FISH is compulsory. So a compromise would be to use c-MYC IHC to screen patients for further testing with FISH. However, since the results of c-MYC IHC do not correlate well with MYC, it is not recommended to use c-MYC IHC as a tool for screening patients, and these are the patients who must compulsorily go for MYC FISH. Now, if Epstein-Barr virus-ish is positive in more than 80% of tumor cells, and particularly when the patient is not immunodeficient, it is classified as Epstein-Barr virus DLBCL, not otherwise specified. So this is another entity in WHO. So the DDs. If a DLBCL is suspected on H&E morphology, and in IHC the tumor cells are negative for CD3 and CD20, what do? So you consider a poorly differentiated carcinoma or a small round cell tumor as a DD. CD20 negative DLBCL and an anaplastic large cell lymphoma are included in the differential diagnosis whenever considering the possibility of lymphoma. If a tumor suspected of DLBCL is CD20 negative, take a history of rituximab administration and verify it. If there is a history of rituximab administration, do a CD79A and verify and identify the B cell lineage as I have discussed earlier. Now, if the patient has no history of rituximab administration, possibility of plasmablastic lymphoma or even an anaplastic lymphoma kinase positive large B cell lymphoma is always considered. For the diagnosis of plasmablastic lymphoma, the plasma cell differentiation should be confirmed through a CD138 staining, and inevitably the Epstein-Barr expression will come. Epstein-Barr virus will aid in the diagnosis. A plasmablastic lymphoma are generally HIV positive, Epstein-Barr virus positive, whereas a multiple myeloma or anaplastic myeloma will be negative. An ALK positive large B cell lymphoma, the B cell markers, the pan B cell markers like CD20, 79, and PAX5 are usually negative, and yet it is a large B cell lymphoma. Here, the plasma cell markers are always positive, and the ALK is strongly positive, confirming a B cell lineage. So these are extremely funny situations where it is a B cell lymphoma without any B cell antigen positivity. Now coming to a primary mediastinal, now many times we are encountered with a mediastinal large B cell lymphoma. Now these lymphomas are seen in young people. They express CD30, they express CD23, and these two markers can help you in the diagnosis. The sensitivities of 30 and 23 are 80 and 70%, so they are not expressed in all primary large B cell lymphoma, so you should keep that in mind. So if both these markers are negative, then the primary mediastinal large B cell lymphoma and DLBCL are differentiated based on tumor location. So mediastinum, so primary mediastinal large B cell lymphoma, patient age, young patient, primary mediastinal large B cell lymphoma, and the characteristic histological findings, which are the nodular sclerosis type of Hodgkin's like lacunar cells in sheets with fibrosis around each of the cells. So that is a chapter in itself. So since we are not discussing morphology, we'll not go into it. So whenever you're having a primary mediastinal large cell lymphoma and you want to differentiate it from a DLBCL, the CD30 and CD23 will definitely help you in arriving at the diagnosis of mediastinal large B cell lymphoma along with clinical features. Double expressors and the way forward. We keep hearing double expressors. So we are talking about MYC and BCL2 are the double expressors DLBCL. And as I said, they are positive for both these markers and they have very poor prognosis. So for the double expressor, more than 50% of the tumor cells must express BCL2 More than 40% of the tumor cells should express MYC. Most double-hit lymphomas show an ISA overexpression of MYC and BCL2. However, we know most double-hit expression lymphomas are not double-hit lymphomas, and hence FISH is essential to diagnose such cases. The cytogenetic FISH testing is a must, is the gold standard, and such tumors have got very poor outcomes with R-CHOP. So these are various 2016 high-grade B-cell lymphoma classification. We will discuss only the MYC and the BCL2 and the high-grade B-cell NOS. There's a lot of morphological discussion this. We will not go into that, except for the fact that high-grade B-cell lymphoma with MYC and BCL2 and BCL6 resembles a Burkitt lymphoma. The starry sky pattern with tingible body macrophages is not the proprietary right of Burkitt lymphoma only. Even high-grade B-cell lymphoma, particularly the double-hit lymphomas, can show such features. So such lymphomas have got intermediate-sized transform cells. Some subtle cytological differences from classical Burkitts may be there, but presence of overtly large cells rules out Burkitt. Burkitt lymphomas are intermediate-sized cells. So when you're seeing various large cells, you're most probably dealing with a high-grade B-cell lymphoma double-hit. Right? Coming to the next point. This we will not consider. The immunophenotype of high-grade B-cell lymphoma, CD19 positive, CD20 positive, 79 positive, and PAX5 positive. But they are always negative for TDT and cyclin D1, because cyclin D1 will be positive in the blastic form of mantle cell lymphoma. So the MYC BCL2 double-hit lymphomas are mostly of the germinal center type, and BCL2 will be positive in more than 95% of such cases. The IRF1 may be positive in about 40% cases, and 75% of such cases will show expression of both MYC and BCL2, which is now called a double-hit lymphoma with a high Ki67 factor, but not more than 90% generally, because the more than 90%, 95% we are dealing with Burkitt's. So the MYC BCL6 DHL express less of CD10, less of BCL2, but more of IRF1. And at about 80% of MYC BCL6 DHL can display the germinal center B-cell phenotype. What are the cases you are likely to misdiagnose as Burkitt lymphoma? We are likely to misdiagnose a high-grade B-cell lymphoma as Burkitt lymphoma because of overlapping morphology, common germinal center B-cell phenotype, and BCL2 negativity. So always keep this in mind. So coming to the diagnostic approach of a blastic type of lymphoma, so the morphology can be a lymphoblastic lymphoma, it could be a Burkitt lymphoma, it could be a DLBCL lymphoma, or it could be a pure mixed type of DLBCL and a Burkitt lymphoma. So the first thing you should do is do a TDT. The moment TDT is positive, you have removed everything because you're dealing with a large lymphoblastic lymphoma. B, lymphoblastic lymphoma is TDT positive. Rest of these lymphomas with a blast-like morphology will never be positive for TDT. Suppose you are dealing with Burkitt lymphoma. So Burkitt lymphoma will be TDT negative, cyclin D1 negative, because the cyclin D1 will be positive in the blastic variety of mantle cell lymphoma. So similarly, MYC and BCL2, and if both are positive, go for FISH, and if FISH is positive, you're dealing with a double-hit lymphoma. So this is how you approach the high-grade B-cell lymphomas, particularly when they look blastic and they mimic either large B-cell lymphomas or the lymphoblastic lymphomas or even the Burkitt's lymphoma. So your TDT and your cyclin D1 are your best markers. The moment TDT is positive, it is large B-cell, it is lymphoblastic lymphoma, and accordingly you can make your algorithm. Now, a very important entity which has been entered in the WHO classification is gray zone lymphomas. Now, gray zone lymphomas are features which are intermediate between DLBCL and a classical Hodgkin. So you do not know whether you're dealing with a classical Hodgkin's lymphoma, particularly the nodular sclerosis, or you're dealing with a large B-cell lymphomas, because the treatment is completely different. So they have got overlapping clinical, morphological, and IHC features between a primary mediastinal B-cell lymphoma and a classical Hodgkin lymphoma. So they will classically exhibit CD45, CD20, CD79A, CD30 will be positive, and CD15 will be positive, but they retain the B-cell phenotype. So here you see, they're expressing 30 as well as 15 of the Hodgkin's lymphoma, but they're also expressing 45, 20, and 79A, but in a higher intensity. right? So that is with the background lymphocytes of CD3 and CD4, and with the clinical features, you can diagnose such cases as gray zone lymphomas or lymphomas in between a classical Hodgkin's lymphoma and a primary mediastinal lymphoma. Now, coming to the recommended panels for small. So far we have discussed all those high-grade lymphomas and various other types of mimickers. For the small low-grade lymphomas, things are very simple. You have an essential panel, CD3, CD20, Ki67, BCL2, and CD10. Optional, CD5, cyclin D1. If cyclin D1 is negative, SOX11, CD23, CD21, 138 kappa lambda, 79A, IgD, IgG, and M. So the four most basic DDs of a small or a low-grade lymphomas will remain as follicular lymphoma, small lymphocytic lymphoma, mantle cell lymphoma, and marginal zone lymphoma. So SLL, the most characteristic finding is that these tumor cells are CD3 negative, CD20 positive, and both CD5 and 23 are co-expressed in tumor cells. Now it is important as a histopathologist to determine if the CD5 is stained in a diffuse pattern, which is seen in SLL-CLL. SLL is negative for CD10 because it does not emanate from the germinal center. Remember the ontogeny? It is post-germinal center, SLL-CLL. So CD10 is negative. So SLL is negative for 10, 81, and FMC7, and negative to dimly positive for CD79B. In fact, there is a saying which says that FMC7 positivity negates the CLL. FMC7 is one of the markers which is strongly positive in all CLPDs except CLL. What about mantle cell lymphoma? The most important markers, CD5 and cyclin D1. However, unlike CD5, which is also expressed in CLL and SLL, the cyclin D1 is definitely strongly positive. And why is this? Because of the CCND1 translocation or the translocation 11 to the immunoglobulin heavy gene, that is translocation 14. So therefore, cyclin D1 is a highly specific marker for mantle cell lymphoma. Occasionally, in 98% cases, you will get it positive. But sometimes when the cyclin D1 is negative, in such cases, apply SOX11 and inevitably it will be positive. Mantle cell lymphoma is usually, but not always, negative for BCL6, CD10, and CD23. But as far as you are concerned, they are all negative. PAX5. This is a B cell activating marker protein. It's a nuclear protein. It's expressed in the nucleus. It is expressed in B lymphocytes and B cell lymphomas. PAX5 is negative in plasmacytomas, also in plasmacytic compositions of B cell lymphomas, T NK cell lymphomas, anaplastic large cell lymphomas, and even the non-hematological malignancies. What about marginal zone B cell lymphoma, lymphoplasmacytic lymphoma, and hairy cell leukemias? All these morphological features have got a nodal, have got a splenic, and have got an extra nodal composition, right? Model lymphomas will always express CD21. And when you see the morphology, there is a characteristic follicular dendritic meshwork, and that is expressed by CD21. So the moment you get a CD21 positive in a CD20 positive cells, it is a mucosa-associated lymphoma of the marginal zone type. The splenic marginal zone B cell lymphomas will sometimes exhibit CD5 in about 20% of cases, but generally, marginal zone lymphomas are CD5 negative most of the time. What about plasma cell disorders? The normal plasma cells are bright CD38, and the CD138 is restricted to the plasma cells only. But remember, CD38 expression can also be seen in hematogones, mature B cells, activated T cells, and even myeloid cells, but at a much lower intensity. So evaluating both CD38 and 138 for a plasma cell disorder is of paramount importance. So just by doing a CD38 only, you're going to miss the diagnosis. Neoplastic plasma cells are 19 negative, 20 negative, 45 negative, 27 negative, 81 negative. 38, 138 are both positive, but shows lower intensity in CD38, but higher intensity in CD138 compared to a normal plasma cell. To get both CD19 and 20 positive in the neoplastic plasma cells is a rarity. CD56 is an aberrant expression in neoplastic plasma cells. It also tells us about clonality. Even CD117 or the c-KIT That can also be positive in 25% cases. Sometimes CD20 in 20% cases. We had a case recently, an aberrant expression of CD20 in a plasma cell dyscrasia. A CD56 negative is seen in plasma cell leukemia, and that is a different entity altogether. Now, the recommended panels for a T NK cell lymphomas, essential would be a CD3, CD20, Ki67, Epstein-Barr virus-ish. Optional panels would be CD4, CD8, 56, 30, ALK, a granzyme, CXCL13, and various other markers. So the first step in the DD is classification into whether you're dealing with a peripheral T cell lymphoma NOS, are you dealing with an angioimmunoblastic T cell lymphoma, are you dealing with an anaplastic large cell lymphoma, or are you dealing with an extranodal NK T cell lymphoma. ALCL is a T cell lymphoma, but the CD3 pan T cell marker is usually negative. However, the CD30 is extremely strong and diffusely positive, and that clinches the diagnosis in a morphology where you're seeing a lot of wreath cells and hallmark cells. Thus, based on the ALK staining, the positive and negative results are classified as either ALK positive or ALK negative, but both will show you a strong diffuse CD30 positive. Because CD3 is generally not expressed in these T cell lymphomas, so you can use additional T cell markers like CD2, CD5, and CD7. And if you've got the TIA1 and granzyme, so be it, you can use that. The most important feature for differentiating ALCL will be from peripheral T cell lymphoma, and the CD30 will clinch the diagnosis because CD30 will never be so diffusely and strongly positive in PTCL as it is in ALCL. AITL, the diagnosis is solely based on the negative or positive immunostaining for markers in the sample. The AITL tumor cells are T helper cell positive. So they are CD4 positive, CD8 negative. And they will have the T follicular helper cell markers as I had told you earlier. So at least two of such markers like CD10, BCL6 along with PD1, CXCL13, ICOS. So if you have a CD10 and BCL6 positive in a proper morphology of AITL, with CD21 as the most important ISC marker of AITL, because the follicular dendritic cell marker is so prominent in AITL. So CD21 positive along with 10 positive, BCL6 positive on a large B cell, which are also Epstein-Barr virus positive. You can get a diagnosis of AITL easily. Finally, the last two slides, recommended panels for precursor lymphomas. Essential, CD3, CD20, CD79A, Ki67, but TDT and CD99 are very important. Optional, CD10, CD19, PAX5, and CD5. T lymphoblastic lymphoma and B lymphoblastic lymphoma are morphologically indistinguishable on H&E stain slides. And if a precursor lymphoid neoplasm is confirmed through TDT and CD99, it is further necessary to determine whether this tumor corresponds to the T or the B cells. The T cells LBL will usually express CD3, but the large B cell lymphomas often does not express CD20. Therefore, if both CD3 and CD20 are negative, the possibility of B cell lineage is confirmed by, again, PAX5, 79A, or a CD19 stain. Let's not forget Hodgkin's lymphoma. Essential, CD3, CD20, Ki67, CD30, CD15, PAX5, and Epstein-Barr virus-ish. Optional, particularly when you're dealing with nodular lymphocyte predominant Hodgkin lymphoma, OC2, BOB1, and EMR. The CHL tumor cells, that is the classical Hodgkin lymphoma tumor cells, will have a characteristic morphology. You all know that, the Reed-Sternberg cells in a proper inflammatory milieu. Differentiation of NLPHL from T cell rich histiocytic lymphoma is a big problem. Here, you will see in NLPHL the rosettes of CD3 or a CD57 positive around the popcorn cells, which are generally not seen in the T cell histiocytic rich. So, suppose we have to do a immunohistochemistry panel in your histology lab. Suspected CLL, SLL, these are the essential panels. CD20, CD5, CD23, CD10, and cyclin D1. Suspected follicular lymphomas, 20, 21, 10, BCL2, and cyclin D1. Mantle cell lymphoma, always cyclin D1, 5, and 20. DLBCL, 20, 5, 21, and Ki67. And Burkitt's lymphoma, CD20, CD10, BCL2, TDT, and cyclin D1. Lot of new things have come up in WHO Heme 5. The beta version is already there. We are still waiting for the hard copy to come. Tumor-like lesions with B-cell predominance have been glorified. The IgG4 related disease, the Castleman's disease. Mature B-cell lymphomas have now been converted into various entities. For example, the hairy cell variant is no longer considered an entity. It comes under the cells with very, very prominent nucleoli. So a lot of new things have come up, but essentially the 2017 WHO classification is the classification which you all should read, and you can add on the new things which have come up in the neoplasms of the WHO 22. The beta version is there. All of you can read the review articles of the beta version, and let's hope the hard copy comes up sooner or later. So these are all the new things which have come up in T cells and B cells, which are beyond the topic today. So to conclude, ladies and gentlemen, IHC staining is an essential for the diagnosis of various lymphomas. It is crucial that the pathologist select appropriate markers according to the clinical situation of the patient, the H&E staining results, and accurately interpret the IHC results from an optimal lymphoma diagnosis. Your morphology is the most important, and thereafter you are applying the IHC, and you are also seeing the clinical features. You cannot do it independently without talking to the clinicians. So the pathologist must collect sufficient samples and properly fix them to obtain accurate IHC results that would aid in a final, reliable pathological diagnosis. Remember, ladies and gentlemen, morphology remains the cornerstone for all future diagnostic and therapeutic modalities. Be proud of the fact that you have got the microscope and you are seeing the morphology. The eye sees what the mind knows. Good night. Thank you very much. Jai Hind. So this is an overview for all the people who have listened to this class. This is an overview. You can always contact me on my email. You can discuss everything with me. But you must have a pattern diagnosis on morphology. And after that, you have to apply all your ISC. But just applying ISC and wasting antibodies is not exactly correct. So your morphological diagnosis, get into a pattern, and then think of the essential and the desirable IHCs you're going to put, and then come to a favorable diagnosis, and also do a clinical discussion with your fellow colleagues in the clinics. If you've got any questions, let me know. You can email me. We can discuss it. You can come and meet me. And I think this is just to incite you to study more, to read more. Lymphoma is a very, very different sort of a proposition, unlike the pattern diagnosis you get. Say you're dealing with a salivary gland tumor or lung tumors, you know the patterns, various patterns. Lymphomas, there are so many mimickers, from the benign to the reactive to the not so reactive, and we always get caught. So do not waste your monoclonal antibodies. Think about the morphology, do a thin cut, get better sections, and your fixation is, if the fixation is optimum, then think of a diagnosis. But I have seen umpteen cases of reactive nodes going as lymphoma and vice versa. So one has to be very, very careful as to how you approach your cases. Thank you very much. If there's nothing more.
Sir, good evening.
Thank you. Who is it? Adi Lakshmi.
Yes,
Okay,
sir, I'm
yeah.
Dr. Deepa. Yeah, Dr. Deepa here. Yes, sir, I have a question for you regarding the IHC internal quality control and external quality control. How can we do the internal and external quality control as per NABL? Because we are going for NABL accreditation,
Yes.
and we are having NABL for IHCs, almost 104 IHCs we are having NABL. But we are stuck up with the external quality control for some IHCs.
So which is your reference lab? Do you compare your IHCs with other labs in your area of practice?
Actually, in Kerala, sir, we don't have Amrita Institute of Medical Science. The only one referral lab we are having. Rest of the yeah.
You know
I'm
what?
from Amrita Institute of
What ideally one should do is that Kerala is a great place. You got some fantastic institutes working on it. I think you all should because this is an unexplored area, right?
Yes,
And
yes.
what you should do is what we had done when we had first started flow
Oh,
cytometry, when we were doing.
yeah, we are doing, sir. We are
Yeah.
doing.
So what we did was we got hold of 3 or 4 institutes.
Okay.
In Delhi, we got hold of Tata Memorial Hospital. We got hold of various other hospitals in and around Delhi. At least 5 like-minded people we got around, and we started comparing our results. Okay. because
Okay,
there was no,
inter-laboratory comparison, you
yeah,
mean?
laboratory, inter-laboratory comparison is a must, because what is more important is honesty, and you are doing your internal audit on yourself.
Yeah, right.
You must audit yourself, because we don't have many of these facilities governing the equals of lymphomas and the equals of flow. A few labs are
Exactly.
doing it.
Some markers are not at all
Yeah,
available.
exactly. So if you have got good internal controls, for example, mantle cells, you got a nice tonsil, you got a
Yes.
CD5 positive. So, if you can have your correct tissues for internal controls using appropriate, for example, CD10, you need some intestinal, material.
Oh,
So
yeah.
tonsils. So you start selecting your tissues for excellent internal controls, and
Okay.
preferably put all internal controls for all the IHC batch or the lot number you're doing it. Are you doing by automated Ventana or manual?
The autometer, yes, sir. We are
Oh,
having
that is
Ventana.
good. What are the problems you're facing in Ventana vis-a-vis the manual one which we were doing earlier?
Actually, it was now it's less time consuming. That is one of the big
Hey, but what
benefits.
is the quality control I'm asking you?
Quality control, we are doing internal quality control, and we purchase some of them from the Vendana person itself.
Okay,
And
good.
calibrators they are providing.
Yeah, so we are
So we
totally
are,
dependent on what they're telling us. So I
yeah,
suggest, if a similar institute is using Ventana, for example, we have started using Ventana, though we are in a very, very early stage of Ventana. You all have done
okay,
much more of Ventana. We in the armed forces also, I was in RR and FMC, the Ventana
okay,
has come up, but we are yet to gain the experience. So I suggest, if you're in a
yeah,
particular institute in Kerala, go beyond Kerala and use
okay.
2 or 3 places which are using the same standards, the same machine, the same calibration, and talk
Okay.
to each other and find out whether you're going wrong or are you on the right track.
Sir,
But I
is it any
still feel,
specification for transporting the samples to outside
yeah,
the
they are
Kerala?
there. So if you say, for example, TMH Bombay, I used to
Okay,
always contact them. So they have got specification. They will guide you, and they will also
okay.
benefit from each other. You will benefit from them, and as they will,
Yeah, definitely.
yeah,
Yeah,
because no one is above something. But however, I will still tell you one thing: if your internal control is good,
yeah, okay.
you have done it. Your internal audit, you audit yourself, do your internal controls properly, and compare with the
Actually, we are keeping
system.
one non-sample or
Yeah,
non-specimen. Sometimes
yeah,
frozen samples also we
yeah.
sometimes
So
not.
every month, whatever is the problem cases, you should
Uh,
discuss with a reference, colleague of yours, whether
okay,
that's in Trivandrum or in Bombay or wherever you think is correct, and
okay,
start sending them the samples according to their guidelines, and
okay.
just get the answer accordingly, so that at least if you do this exercise for 2 or 3 months, you will know where you stand.
Yeah, where we, yeah,
Yeah.
is exactly,
So I
sir.
think
Oh,
exposing yourself to an audit by another reference lab is the answer.
yeah. Okay, so is it not, that means it's not mandatory for doing the external quality control, or
Internal
we can
control
go
is
for
must.
internal,
Yes,
interlaboratory comparison is good enough.
absolutely, absolutely. There's no way.
Yeah.
We are doing the
Okay,
same.
thank.
We are doing the same.
Okay, okay. Thank you so much, sir. Thank
You're
you.
Sir,
most welcome.
there is one more question, sir.
Yes.
How to differentiate infectious mononucleosis and Hodgkin's using IHC?
Oh, this is an age-old question, but it's a very interesting question. So recently, a senior pathologist from a reliable, good college, son got diagnosed as Hodgkin's lymphoma, and it was infectious mononucleosis. So number one, clinical features. Number two, the morphology. So all these cells are immunoblast-like cells, right? All these cells will be Epstein-Barr virus positive, and there'll be a plethora of immunoblast and immunoblast-like cells, which will be mimicking the RS cells, but they are not RS cells. They are B cells, and they will all be positive for ISH, Epstein-Barr, or an LMP1. So, clinical features, morphological features, and if there is a problem, then you do the IHC, where all your immunoblasts will be CD20 positive and Epstein-Barr virus positive. And you have to reassure the patient that this is self-limiting. Don't give any antibiotics. Wait and watch. And you will succeed, because we did the same thing with at least 3 such cases. And all of them, you know, went down, beautifully. And they were all diagnosed as classical Hodgkin's lymphoma, unfortunately.
Thank you, sir.
Anything else? Lymphoma, IHC is a huge chapter. One has to standardize this in your lab, you have just listened to my lecture. After huge experience, I've done this. I've standardized many things in my armed forces experience. But at the end of the day, you have to decide what you want, how you decide it. These panels are all just guidelines. You can make your own panel based on your acceptability. You can share my email, Khushi.
Yeah, yeah.
You can share my
Okay,
mail
so
with
that's
everyone, and I'll be very happy to answer on the mail, because you just can't ask questions in a limited period of time. So give my mail to all of them, and anyone who has any query or anyone who wants to set up IHC panel, how to set up, I'll be most happy to help you out. Okay, because I've also gone through the grind, and it has taken me quite a long time to come to this level. So I'll be happy to share everything with you. You share my mail, Khushi, with each one of them.
okay, sir. I will do that. I will do that.
Yeah.
So can we end here?
Yes, I need a hot cup of tea.
Yeah, of course, sir. So thank you, sir, for taking the class.
Yeah.
And we expect you in the near future again as a
Yeah, yeah.
faculty of Masterclass.
Sure, sure. Thank you very much. Good
Okay,
night,
thank you,
everyone.
everyone. Thank you, sir. And thank
Bye.
you, Vigodu
Bye.
team.
Good night.
Thank you, sir.
Bye.
Good night, sir.